Are you a marathon runner, know someone who is, or perhaps you have provided marathon medical support? More people are running marathons in the U.S., but has marathon-associated cardiac arrest increased? Also, after cardiac surgery, is prothrombin complex concentrate effective for coagulopathic bleeding? And in patients with heart failure and iron deficiency, does IV iron reduce time to cardiovascular death? Hello and welcome to our listeners around the world. Today is Friday, April 4th, 2025. I'm JAMA Deputy Editor Dr. Linda Brubaker, sitting in for Editor-in-Chief Dr. Kirsten Bibbins-Domingo. I'm joined today by JAMA Deputy Editor Dr. Chris Muth. Before we get into this week's research, we have a timely medical news update. JAMA just published a late-breaking article discussing the steep personnel cuts and a major reorganization at the U.S. Department of Health and Human Services. This past week, layoffs began for approximately 10,000 federal employees at the FDA, the CDC, the NIH, and CMS. In interviews with JAMA's news team, public health leaders shared their concerns for the health of the nation. Now let's turn to this week's research, Chris.
The American College of Cardiology held a meeting last weekend in Chicago. JAMA and JAMA Cardiology published some great research articles featured at the ACC this year. First up, the FAIRS-2 trial by Dr. Karkuti and colleagues, in which they compared two strategies for coagulopathic bleeding after cardiac surgery, frozen plasma versus prothrombin complex concentrate, or PCC. In this trial, the investigators reported that participants who were randomized to receive PCC experienced superior hemostatic efficacy.
That's a finding that could certainly affect clinical practice. The trial report is accompanied by an editorial by Drs. Wong and Bennett Guerrero. The authors discuss the emerging clinical benefit of PCC highlighted in this trial, while calling attention to important considerations such as costs and availability of point-of-care INR testing.
Continuing on with cardiac concerns, JAMA also published a research report by Dr. Anker and colleagues assessing the efficacy of intravenous iron in patients with heart failure and iron deficiency. Trial participants received either ferric carboxymaltose or saline placebo, with the median follow-up of 16.6 months. The authors reported that ferric carboxymaltose did not significantly reduce time to first heart failure hospitalization or cardiovascular death in these patients.
Interesting. Thanks, Chris. And there is a lot of curiosity about the cardiac demands of marathons in recreational runners. Dr. Kim and colleagues assessed cardiac arrests during long-distance running races and reported that the incidence of cardiac arrest has remained relatively stable since their earlier report in 2010, even though participation in long-distance races has increased in the U.S.
Well, that's reassuring, and it highlights the need to focus on prevention. In their editorial, Drs. Patel and Link also emphasized the success of effective emergency action planning during races, like access to defibrillators. Let's listen to a clip from the related JAMA Author Interviews podcast.
I also think we have a sobering side of this story, and that is that although you were more likely to survive a cardiac arrest, we haven't seen a decline in the cardiac arrest event incidence. And so I think we've attacked kind of the downstream part of the problem, and that's what to do when someone arrests. But we still have work to do on the upstream, and that's thinking about how to prevent the arrest from happening in the first place. And a lot of this gets back to recognition of the fact that no amount of fitness, no amount of strength, no amount of prowess is protective against underlying cardiovascular disease completely. There's no such thing as immunity from heart disease if you have particular risk factors for coronary disease. So that is a message that's not necessarily new, but one that hopefully RACER2 will again remind people of and help clinicians all over the world think about the concept of no one walking in the clinic being too fit to have a problem. And this is where we have an opportunity to continue to identify, risk stratify, and hopefully prevent further cardiac arrest from occurring.
Chris, let's turn to some JAMA research letters. Vaishnavi Krishnan and colleagues investigated predicted risk for cardiovascular disease in U.S. adults. They enrolled participants who were 30 to 59 years old and used the PREVENT model to predict 10 and 30-year CVD risk. The authors reported a discordance for some individuals, finding that almost 15% of individuals with a lower 10-year risk had a higher risk of CVD at the 30-year mark.
Yes, seems important to be aware that some people with a lower, shorter-term risk may still have a higher risk over a longer time period. Linda, JAMA also published a research letter about how deporting immigrants could affect the healthcare workforce. Dr. Azaroff and colleagues used the 2024 Current Population Survey and U.S. Census Bureau supplied weights for national estimates. They estimated that over 2 million naturalized citizen immigrants and over 1 million non-citizens work in healthcare.
That's a bigger number than many people may have guessed. Dr. Tadros and colleagues contributed a timely research letter about the effects of trade tariffs on Canadian pharmaceuticals. In their cross-sectional analysis, they estimate that $3 billion in U.S. pharmaceuticals depend on Canadian manufacturing, with 25% tariffs adding $750 million in cost.
And in another research letter, Alexandra Potter and colleagues estimated preventive services use among adults in the U.S. The authors evaluated breast, colorectal, and lung cancer screening tests among U.S. adults. They found that breast and colorectal cancer screenings were more likely to be used than lung cancer screening, even though patients were also eligible for lung cancer screening. Let's listen to a clip from the related JAMA Author Interviews podcast.
So in terms of things that we've been exploring, the reasons why lung cancer screening rates are thought to be so low, it's a complex topic. But a lot of people anecdotally have this notion or even bias that individuals eligible for lung cancer screening may be hard to reach and less receptive to participating in preventive healthcare like cancer screening. And I think this is because lung cancer screening is currently recommended for individuals with a history of smoking, and there's a lot of stigma associated with smoking. We know that smoking is more common among individuals with lower socioeconomic status, in individuals with mental health conditions. And I think there's a belief among many in our field that, well, individuals who are eligible to get screened, they're just hard to reach. And some may even say, tough luck, that's a big reason why lung cancer screening rates are so low. But all these beliefs and notions I've mentioned here, there's no empirical data to back this up. And I think this is all related to stigma and bias. So we wanted to ask a very simple question for this study, which is, are individuals who are eligible for lung cancer screening truly resistant to receiving preventive healthcare, or is there something else going on?
There's a thought-provoking group of JAMA viewpoints this week, Chris. Dr. Suchi and colleagues wrote about artificial intelligence in medical education. They discuss how large language models can enhance foundational skills and offer new opportunities in medical education curricula. Dr. Opel and colleagues discuss recent changes to funding for NIH vaccine uptake research. They explore the ramifications of this decision and emphasize the importance of this research for public health.
For this week's JAMA clinical content, Dr. Kim and colleagues provide a review on small cell lung cancer. They give an overview of small cell lung cancer as well as management of limited and extensive stage disease. There's also an accompanying JAMA Clinical Reviews podcast.
JAMA also published a clinical review by Dr. Auerbach and colleagues about iron deficiency in adults. They discussed pathophysiology, risk factors, and management for low iron stores with and without anemia.
And the JAMA Clinical Guidelines synopsis is all about the care of patients with chronic venous disease of the legs. Dr. Goodman and colleagues summarized the screening and management recommendations for telangiectasias, as well as varicose and reticular veins.
Let's also talk about the JAMA Medical News article written by news intern Nora Collins. She reports on genetic discoveries that could lead to precision treatments for depression and bipolar disorders.
And she also reports on an interview with JAMA Plus AI Editor-in-Chief, Dr. Perlis. He sits down with Dr. Munrai and Thomas Buckley from Harvard Medical School. They talk about using open versus closed-source large language models for complex medical diagnoses. And there's a related JAMA Plus AI Conversations podcast as well.
Wonderful, Chris. JAMA covered quite a range of impactful clinical content this week. And thank you for tuning in to hear what's new at JAMA. These highlights were brought to you by Dr. Chris Muth and me, Dr. Linda Brubaker. This episode was produced by Daniel Musisi and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in the episode show notes. To To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.